Okay.
Well, welcome everybody to the spring 2022 meeting of the Virginia Heart Attack Coalition. We're really excited. We think we have a great program tonight that'll interest a lot of our stakeholders. We're going to be talking about pulmonary embolus from the field to the cath lab. Well, I think most of the folks on this call know who we are. I'm Dr. Peter O'Brien. I'm the cath lab director at Centra Lynchburg General and also one of the co-founders and steering group members of the Virginia Heart Attack Coalition and Virginia Cardiogenic Shock Initiative. But for those of you who are newcomers and don't know what VHAC's all about, we are a voluntary statewide organization that works collaboratively to improve the systems of care for the early recognition and treatment of all Virginia residents having heart attacks. And as I've said, over the past 14 years that we've been in existence, Stemi is really a team sport. And it's no longer just the province of cardiologists or a certain department. It really involves multiple stakeholders working together to deliver the best possible care. And I always like to show this slide because this is where it all begins. This is a paramedic with a pre-hospital EKG, and this is the first step, recognition and getting that patient on through the emergency department to an open artery in the cath lab. So VHAC has always been a very EMS centric organization, always very focused on education, advocacy, and any way to help our colleagues provide the best care possible. So, for anybody who's ever tried to improve a system of care for a single healthcare system or EMS agency knows this can be very complicated work. So we came up with a strategic plan when we started, gosh, now way back in 2008, that I think has served us well over the past decade and a half. The first is sustainable regional activity, which I'll mention tonight, mainly in the form of what we've been up to in our meetings since we last all met. The next is EMS education, training, equipment. Again, I show that slide to show you that it's not just what I do or my colleagues do in the cath lab that really makes a difference. It's everything that happens up to the doors of the cath lab. So that's a very important part of our work. And then finally, any quality improvement initiative that is really worth its weight has a way of monitoring that data, of collecting that data, of holding ourselves accountable and reporting that to our stakeholders to help drive that quality improvement change. We are a really kind of a loose organization or confederation of 6 regions. That's how we try to, as I mentioned, this is complicated work. So one of the first things we did was to break the state of Virginia up into 6 regions. These are loosely based on EMS councils, and those are the PCI centers superimposed, because we know that each region shares some similarities in their challenges, their barriers to care, but also some differences. What keeps us from getting a first medical contact to balloon time less than 90 minutes in Southwest Virginia is going to be a little bit different than that in Northern Virginia. So we knew we had to break the state up into these regions and really recruit local leadership and have the boots on the ground. Well, the other thing that has happened over the past 14 years is that we have evolved. We are not just about Stemi anymore. Last year, we were approached by Dr. Behnam Tehrani, the cath lab director at Inova Fairfax, with just a fantastic idea. And that was to begin to look at systems of care, not just for Stemi, but for cardiogenic shock. And the cardiogenic shock initiative was born and has really become a part of VHAC. And I'm going to tell you some of the updates on that tonight, some really exciting stuff that's happened. If you remember, for those of you who were with us back in September, we had a whole evening program dedicated to the latest and greatest in shock care and some of our plans for organizing the state. I'm going to tell you a little bit more about that. So what have we been up to? Well, a lot of our work is still remote coming out of the pandemic. We have a monthly call with our steering group, And basically what happens is those 6 regions send their stakeholders to the table, the virtual table, if you will, to present their first medical contact to balloon data, other activities, challenges, successes, how they've engaged or what they've done with EMS and other stakeholders. Along those lines, and I won't get into great detail on this tonight, but there is a bit of a revolution happening in pre-hospital care and pre-hospital data, and that is ESO, which is new software, patient care records that are allowing us to sort of collect that data with EMS and breaking down some of those silos, some of those barriers to getting the data from what happens in the field into our registries and what's happening in the hospital and in the cath lab. So stay tuned. That has really been a sea change in what's happening with EMS data collection and really Stemi data. So in terms of our calls, our meetings, our activity is really 1 part Stemi, 1 part cardiogenic shock. So what has happened since we talked in September? Well, our hospitals have finalized their shock protocols, which has been very, very exciting. And they have brought those to the table. We shared those, we looked at them, discussed kind of what the science tells us and how we want to apply these best practices. The next thing we resolved to do was to identify our shock patients, which sounds somewhat simplistic, but you'd be surprised. We feel like there are shock patients who are identified late in the course and maybe never before they really start to decline. The most straightforward or reproducible way that we can see to do that is by using NCDR chest pain MI. And just for clarification, we're looking at acute coronary syndrome MI shock right now. So that's the phenotype that we're focused on. We want to make sure that the shock protocols are applied to appropriate patients. We know we all probably have plenty of patient care pathways and protocols and various things kind of gathering dust in those 3-ring binders. We don't want it to be like that. We want these to be active, living documents that help identify and guide the care of these patients. So we also wanted to have deliverables so that when we meet again this summer or next month, we have stuff to bring to the table, that we don't just kick these ideas around month after month, that we actually hold ourselves accountable. And there were lots of things that we kind of bandied about, what we should look at in terms of performance measures, outcome measures. And we actually settled on 2 things, cardiac power output and lactate. Now, you may wonder, with all the stuff we could look at, why don't we just focus on these 2 things? Well, cardiac power output tells us a lot. It tells us that you've identified that shock patient, that the appropriate shock patient has a right heart cath, and that you're looking at a very important variable. So cardiac output times mean arterial pressure divided by 451, I think we're all kind of getting used to that, is really starting to drive decisions in terms of pressures, mechanical support, stuff like that. And then also lactates, something we can follow. It gets us thinking about the pathophysiology. You can monitor the patient's progress, whether it clears, increases, or what have you. So one of the things that we've learned over the past 14 years is if you want to make big changes, you got to start simple, and it's got to be a well-defined, concrete set of goals. So hopefully we've started on the right foot. So I want to now talk about the Stemi data for the state of Virginia and the Stemi database. I touched on this over the course of the last several meetings, but we've made some exciting progress, and I actually have more numbers to show you tonight. So I think that's pretty enticing as well. We have always been very, very driven by the data. Again, VHAC, shock, did not want to just be one of these sort of all get together and kick around great ideas and nothing happens. We don't ultimately have the data to tell us how we're doing. And over the first decade of VHAC, you can see that we made tremendous progress in the median first medical contact to device time in the state of Virginia. But I actually didn't include the years down there. This ends in 2017 when the action registry broke up. And for about 2 or 3 years there, we were kind of adrift. What were we going to do now? We have some hospitals on chest pain MI, others on get with the guidelines, some on neither. How are we possibly going to figure out how we're doing and drive further change? And that's when we began to partner more closely with VCSQI to develop a new registry and a new way to aggregate and report that data to our stakeholders. And this is a schematic of that data aggregation model. Basically, it starts with the registries that our hospitals are already using. Get with the guidelines in chest pain MI. Individual hospital data is uploaded to ARMIS, which is a vendor that helps aggregate that database and then report back to the hospitals and also to the VHAC regions. So very, very exciting. And this is, now this is one thing that's a little bit of a downer. I was hoping to come tonight and tell you that a bunch more hospitals have signed up for this, but we've kind of plateaued a bit at 17 members. We do have 2 new memberships pending. And I'll touch on what you can do and how you can sort of help your hospital leadership, move forward on this, because it's going to be so important. We are excited to say, though, that from a technical standpoint, we think we're going to be able to upload Get with the Guidelines by June of 2022, June of this year. So stay tuned on that. I want to show you what the data looks like. This is the 4th quarter of 2020 to the 3rd quarter of 2021. Now, again, we had a lot of stuff we could look at, but we wanted to focus on a limited number of variables and ones that we thought were high value, things that really drive change in a system. So we looked at door in, door out. We looked at transfer times for non-PCI to PCI hospitals. We looked at percentage under 90 for first medical contact to primary PCI. We looked at the median time and also the use of pre-hospital EKGs. So I'm just going to highlight 2 numbers to kind of fix your eyes on. The first is percentage less than 90 minutes, 75.3%, and then the median first medical contact was 75 minutes. Well, moving into a full 4 quarters in calendar year 2021, those numbers have improved. The median first medical contact to device is down 2 minutes to 73. And the percentage less than 90 minutes is up almost a full 10 percentage points, up to 84.8%. So very, very exciting. A couple of the other things haven't moved much. We're working on that, but I think we're seeing these performance measures trending in the right direction. And I'll show you that in another form, which I think is pretty striking. And I think it's a great proof of concept that the work of VHAC and later the work of SHOC is work that is really, really worth doing. And we are very grateful to all of you who have helped us with this. And well, actually, I got a little bit ahead of myself. Let me show you, though, when I mentioned that you could report this data out by regions, that's what we're moving towards as well, which for VHAC, our model is very, very important because we want hospital level data, but it's regionalized systems of care. So we want to know how these individual regions are doing. And you can see when you break it down, how those numbers stack up. These are kind of the trend lines that I wanted to show you, and it shows that we are making steady improvement in our median FMC to primary PCI times. So this is, I think, due to the increased focus and the efforts and really having the assistance of ECSQI and that infrastructure behind us. And I think it also is because we're coming out of the pandemic. I don't want to jinx us. Maybe we're finally coming out of the pandemic and hospital resources are not as stretched. We don't have PCI centers on diversion and all the other disasters of the past 2 years. So that's very, very encouraging. I just want to close out by saying that we need your help. If your hospital is not a member of ECSQI, I would strongly encourage you to join. I really do think this is the future of quality in our state. I think Virginia is way ahead of many other states in the union with an organization like this. We are not just about Stemi, we are about and SHOC, we are about everything from blood product usage after CABG and valve surgery to acute kidney injury after PCI, outside angiogram reviews of the appropriateness of your PCI, all kinds of great stuff really comes with the package. If you are a member of ECSQI, please get the data use agreement signed so you can join the STEMI registry that I showed you. I know how this stuff works. It gets to your administrators, it sits in legal, it's kind of hard to get the ball rolling, but I would say if you're at that stage, camp out by their office, follow them to the parking lot, whatever you need to do, just help us get this done, because I would love to see all 45 plus PCI centers in the state of Virginia, members of ECSQI at some point, and then members of the registry and submitting data. So that's just my kind of shameless pitch to recruit and ask for help in this. So that concludes the state of the state with VHAC, with shock. Again, tremendous progress, still a long ways to go. I want to just take a second to thank all of our stakeholders. You guys have done a tremendous, tremendous job. Thank you for all the work you've put in over this past year. And I think we're, like I said, I think the ship is heading in the right direction. Well, I'm now excited to turn this over to a panel of expert speakers on pulmonary embolus. Again, I think we have a very interesting program tonight. We're going to hear from 3 separate speakers, and then we're going to have kind of an open question and answer period, and also put some questions out to you, some surveys to see what the state of PE care is at your hospitals. I want to turn it over to Dr. Glenn Druckenbrod, who's the medical director and vice chairman of the emergency department at Inova Fairfax, and he's going to give us a very interesting presentation on identifying PE, how to triage, who you can send home, who you should send on for interventional therapies and whatnot. So without further delay, Glenn, take it away.
Thank you very much. I appreciate the opportunity to come before everybody. There you go. So we're going to chat. Let's see here. Controlling screen 2. Sherry? There we go. So let's talk a little bit about pulmonary embolus just from a definition standpoint. Most of us know what it is, but a blood clot or a thrombus in one of the arteries going to the lungs, blocking all or part of the blood flow. Causes hemodynamic changes in blood flow, and it increases the pressure in the normally low pressure system on the right side of the heart. The interesting thing about pulmonary embolism compared to the other clot diseases that we deal with all the time, Stemi and stroke, is that the problems caused by the clot are not caused by the downstream effect of blocking the organ. It's caused by the hemodynamic changes that take place. Think of the 2 ventricles as kind of twin brothers. One's kind of the couch potato, and one's kind of the athlete of the family. And the right side does very well sitting on the couch eating chips for the most part, because he's not asked to do very much. And then when a PE happens, it changes the entire hemodynamics, and that's what causes most of the issues that we're going to see. So basic definitions that we talk about, and it really creates language we can all understand. So hemodynamically unstable PEs are called massive or high-risk PEs. And those are not hard to figure. They come in, they're hypotensive, they're tachycardic, you can't oxygenate them. They're clearly hemodynamically stable, and they're having major effects from their PE. Then we have the hemodynamically stable PE. Blood pressure is okay, pulse is okay, but when you get their blood work or you get their echocardiogram, they're showing evidence of right heart strain. So even though the body's compensating, the heart's struggling, and that right side of the heart is really having trouble kind of keeping up, if you will. And then we have PEs that have no evidence of strain. Your cardiac markers and whatnot are normal, and those are low risk. And the reason those definitions are important is that it allowed people along the continuum of treatment to be able to have a common language to speak about what's going on with a particular person. Because there are lots of PEs you'll see that are very big from a clot standpoint, but are doing nothing to the heart, and others that aren't that big, but are causing major issues. So it allows us to have a language to be able to talk to each other. So what happens? You know, there are multiple mechanisms that are causing abnormal gas exchange. And the key feature is that the blood cannot get through the lungs to oxygenate, and you create a hypoxic condition. The blood not being delivered to the left side of the heart creates diminished stroke volume and cardiac output. So even though the heart is healthy and doing what it needs to do, it's not being given anything to which to pump out to the rest of the body. So the athlete of the family is getting annoyed because there's nobody giving him anything to eat. The pulmonary vascular resistance increases, and that causes strain. As I mentioned, that right side of the heart really doesn't have a lot to do for the most part. And when that clot happens, it increases the strain, and suddenly you take your couch potato out and put him in a marathon, and very quickly he's going to struggle to keep up. And that's what happens. This whole cardiopulmonary circulation becomes undone. And as you'll hear from the speakers later on, the onion around vascular flow throughout the body is really much more complicated than we would think. And you can keep peeling and peeling and peeling until you finally understand, I'm not a good peeler. That's probably why I went into emergency medicine. So if the right ventricle can't generate the appropriate pressure to allow blood to flow through, then you get collapse. And those are the patients you see. They can either drop dead right there, they have their syncope, or they come in and no matter what you do, you can't seem to get the blood pressure up. You can't get them oxygenated because the system is just collapsing. So let's talk about the risks and the symptoms. Most of us know that the classic symptoms of shortness of breath, chest pain, oftentimes pleuritic, cough, they can syncopize or have hemoptysis at the extreme ends of it. They're typically present tachycardic, tachypneic, and hypoxic. And the risk factors we think about all the time: immobilization, recent surgery, cancer, hormone replacement therapy, inherited clotting issues, which we've learned a lot more about in the last 10 years, and prolonged travel. And for the most common drug associated is always going to be in the female of childbearing ages on oral contraceptives. It becomes a big issue. So let's think a little bit about the pre-hospital considerations that, our pre-hospital teams have become great about bringing the emergency department to the patient, essentially, especially for cardiac arrest. You can do almost anything in the field that we can do in the hospital to get that heart restarted and to get the circulation going. PE is the one area where we're kind of in the old-fashioned scoop and run, because there are some interventions that we can do in the hospital that are not easily brought to the field. So we think about that, trying to do whatever you have to do in the back of the medic, but get that person on the way to the hospital, because there are interventions we can help. And be careful with fluid resuscitation. Especially in the sepsis age, we've all been taught 30 per kilo, and we bolus patients who are in shock. It happens all the time. But in PE, if you fluid bolus, you can actually worsen the hemodynamics. And it's sometimes the tip-off, especially out in the field, that you're dealing with a PE, is that you fluid bolus somebody who's in shock, and actually it seems to get worse. And that's sometimes, think about this, maybe a PE that wasn't evident when you first saw the person. So be careful with the fluids and think about rapid transit, because it's very important. We can do some things. Even on people who are in very low flow states, we can sometimes salvage. And a lot of times these are in young, otherwise healthy people, so they have a little bit more time than the typical 85-year-old cardiac arrest that we might see. So what do? The first thing is an H&P, the high index of suspicion needed, because the symptoms I mentioned before are classic, but really it runs the gamut of very low symptomatology to complete collapse. And the joke phrase we use in the emergency department when someone presents a difficult case to you is, well, could it be a PE? And the answer to that question is always yes. Whenever someone brings it up, it just adds to the differential. PE is always there, and because it's really a great mimicker. It can present like a lot of things. We support the oxygenation as needed. I mentioned about the careful fluid resuscitation, but it's important, especially if we have places that treat with interns and residents and whatnot, and they're slamming fluids into a person, and the person's not getting better because you're actually making the underlying issue worse by giving too much in the way of fluids. We do lab work on these patients. Basic CBC, BNP, coags are important for ongoing therapy, but we look at the BNP, troponin, and lactate to get a sense of the stress that the body is under and what kind of strain the heart is dealing with. And when we talk to our colleagues later on, we'll talk about our PERT teams. These are the things that we're looking at to kind of help us make a determination of what the next step is going to be. From a diagnostic standpoint, CT angiogram has been the gold standard. It's now, over the last, I'd say, 5 years, that bedside ultrasound is becoming much more utilized, and practitioners are getting much more skilled at being able to, right at the bedside, look and get evidence, see if there's evidence of right-sided heart strain by the ultrasound, and it's helping us make a diagnosis quicker. It's also helping us get these people anticoagulated. In the past, we used to sometimes wait, oftentimes very long, to anticoagulate, wait until we had a proven disease. But when we can see it on the ultrasound, we can get these people anticoagulated as fast as possible, which is really the thing we can do to stabilize a person the best. So the CT angiogram, as I said, is very sensitive. It's very informative. One of the issues that we worked with through our PERT team, and it was very important, is that we created a common language with radiology to talk about a PE, so that as everybody can hear the same thing, and the radiologists now are very good about talking about these things: high clot burden, giving us an RV to LV ratio, looking at whether there's main pulmonary artery clot or saddle emboli, and is there clot visualized in the heart. Before, some of the readings were just, they had a PE, but now being able to talk about this in particular, you'll see around the team members, it makes a big difference at how we stratify what we should do and what the risk the patient has. So diagnostics, to continue, if there's evidence of instability or laboratory markers are positive, we go to early bedside echocardiography. We want to know if that heart, the right side of the heart, is having significant strain. This helps guide our potential intervention. And as I mentioned before, our bedside providers are becoming very clear. We can actually look at the legs easily and then look at the heart to see what we're doing, and that helps drive downstream treatment. Emergent treatment is, some of it's self-evident. We want to replace your oxygen as quickly as we can to get you up to something, hopefully above 90%. As I mentioned, we anticoagulate as soon as we strongly suspect PE is in the differential or the diagnosis is made. Sometimes our door to anticoagulation can be hours, and that's really struggling, especially people who are throwing ongoing clots. We really want to stop that process as soon as possible with the anticoagulation. Thrombolysis, we can thrombolyze someone over the course of 2 hours, the way we typically do for people who are decompensating but stable, and then we can give TPA emergently for cardiac arrest. And that's what I mentioned before for the people in the field, that a lot of these patients have a low flow state that you can't really feel a pulse. They're kind of in PEA, but they're actually moving a little bit of blood, and getting the TPA during those cardiac arrests, actually we've salvaged a fair number of people doing that. And then you have your advanced treatments, which you're going to hear about momentarily. Catheter-directed TPA, IR clot removal, CT surgery, ECMO support, intensive care unit management. I can remember one of the earlier patients with our PERT team, we cannulated at the bedside a young woman for ECMO, and she actually survived. That I was just amazed at watching all the cogs of that wheel that were working to get somebody on ECMO at the bedside in the emergency department. It was pretty impressive to watch. So there are a lot of things we can do to help stabilize. So the PERT team, we've been having a PERT team, I think it's 8 or 9 years now that we've been working, this pulmonary embolism response team. And why? It's kind of like the why we do for a lot of things that are interdependent. It gives the bedside clinician, often the emergency physician, to harness a multidisciplinary team to assess and gain access to the full range of medical procedures. The problem for pulmonary embolism is that it's not quite a cookbook. It's not like Stemi. Let's get you to the Cath lab and get that vessel opened, or stroke, let's get the TPA and get you to IR so we can get the brain flow going. What you do, when you you intercede is not fully said yet or fully determined yet. And it takes a good conversation with your partners who have a lot of experience in this to figure out what the next step should be. We found at Fairfax, the reason we started the PERT process there, it had been going on around the country, but we kind of joined in, is that the specialty services were being asked to see patients too late to make a difference. So when the person had collapsed or the person just wasn't getting better, they've been on the floor for 5 days, and then they were getting consulted with IR or something else to be able to do something, and at that point it was too late. So that's why we created this service. So in practical use, this team has really elevated the care for the PE patient in the emergency department. We have all stakeholders aware of the patient, allowing early intervention, and then they're also in daily contact with the patient. So if they change, the therapy can change if the patient worsens. It actually has made a big difference. As I mentioned before, this is a very complicated disease process. You're going to hear and see later on with some of the things that happen, but as I said, it's not cookbook. It takes a really reasoned approach to how to deal with these patients and long-term follow-up to make sure that the right-sided heart disease doesn't become a lifelong process. So it really makes a big difference for patients. And that's why I finished with, it's not a cookbook, it's not obvious, and it takes an interdisciplinary team to figure out what the best treatment should be. So I just wanted to give you a quick rundown just to look at what we've seen in the first quarter of 2022. Number of PE patients, we've seen 85 of them. 55% of those are admitted to the inpatient service, meaning they're sick enough that they're admitted for long term. The observation admissions are around 20%, and then we've discharged 20% from the emergency department and one patient to the morgue. That's over the first 3 months. So discharge from the ED is kind of an interesting process. I'm not sure 10 years ago any of us would have thought, well, sure, you have a PE, you can go home. That wasn't something that we thought about. But we had been doing for a long time discharging DVTs with outpatient anticoagulation, and we used that as a template to discharge PEs. When we first started doing that, I'll be honest, it was a pain in the butt because you had to do Lovenox and then bridge them to their Coumadin and wait till their INRs were out of whack. And it was just a pain in the neck trying to discharge patients and get them set up for anticoagulation. But the new drugs, the new generation of anticoagulations makes discharge easy and makes immediate anticoagulation, which is very important. There were multiple ED evaluation and risk calculators that allow us to safely determine who's a low risk PE and how to do it. Here at Fairfax, we contact pulmonary for everybody we send home, and we make sure they have close contact with pulmonary as a follow-up. And so far, since we've been doing this, we've had no untoward returns to the emergency department, so that it seems like that our calculations are right and we're sending low risk patients home and they're doing well. They're not having decompensation at home because we're not admitting to the hospital. That is the end of my part of this talk. I'm happy to take any questions and any other suggestions or input that you guys have. And Dr. Sarin is taking over from me after this. He has the next presentation. Dr. Sarin, you're on mute.
Yeah, I can see it. All right, thank you very much. Thank you for this opportunity to speak. I really appreciate it. I hope you guys can all see my my slides here. I'm Shawn Sarin. I'm an interventional radiologist here at GW in Washington, D.C. And as I was preparing for this talk, I realized the crux of this situation is the importance of the right ventricle. As thrombus goes to the right side of the heart and increases the pulmonary vascular resistance, the right side of the heart really is not designed, as Dr. Druckenbrod mentioned, it's really the lazy cousin or the lazy brother who's not used to working against the increased strain. And so that's why it's so important to look at the right ventricle. Imaging, echocardiogram here on the left, you can see a normal RV with a good squeeze. And this is typically what we see when we're consulted for these pulmonary emboli patients with a really akinetic RV. On CT, you get instant evaluation. Though it's a snapshot, you can quickly identify in just seconds how bad the RV is strained. We normally look at a ratio between the right ventricle and the left ventricle, and anything over 0.9 is thought to be abnormal. You can imagine that this is hard for a radiologist to interpret, thousands of images and give an accurate estimate. And that's why, there may be a role for artificial intelligence and giving us dynamic evaluations of the RV. We're already getting a CAT scan. If AI can quickly look at, the RV and help stratify and give us some kind of decision support as to which patients require what kind of intervention. So as Dr. Druckenbrod mentioned, the standard of care is really anticoagulation. But we've also looked at over the decades preceding us, thrombolytic therapy, either IV systemic therapy or catheter-directed lytic therapy. That's been done since probably the late 80s or 90s. IVC filters certainly have a role in the care of these VTE or venous thromboembolic patients. But over the last 2 or 3 years, there's been a resurgence of interest in thrombectomy, not so much surgical, but clearly endovascular. The endovascular devices that we have, they include, again, catheter-directed lysis devices and also these thrombectomy devices. Now, the infusion catheters we have, they're basically leaky garden hoses that allow us to drip TPA into the pulmonary arteries. It's very low profile. It's about the size of an IV, and we infuse TPA over a couple of hours. This is maybe a $60 device. The ECOS catheter builds on an infusion catheter, but also has an ultrasound crystal that allows for breakup of the thrombus or accelerates breakup of the thrombus, hoping that the fibrin will degrade allowing more TPA to penetrate the thrombin and accelerate its lysis. To their credit, this company, who was acquired by Boston Scientific recently, they were the first ones to come up with even randomized controlled trials regarding this technology. And we'll briefly touch on that in a moment. This is what one of these kind of procedures looks like. It's very simple. Sometimes we come from the jugular, sometimes we come from the femoral. This is what these ultrasound crystals look like as we place them in the pulmonary arteries. The Penumbra Indigo is basically a straw. It's a 12 French system that's attached to a microprocessor that calculates when the catheter is up against thrombus and then accelerates aspiration. When it's up against the wall, it can detect that. When it's in a widely open vessel, it'll actually turn off the aspiration so you reduce blood loss. A pretty interesting device. That's what we frequently use for stroke. The Inari FlowTriever, I believe it was 2018 when it came on, when it received its 510K clearance. It's a much larger aspiration catheter, ranging from 16 to 24 French. And it also comes with these kind of metal or nitinol brushes that can help us scrape up some clot. Very interesting, very powerful device. The AngioJet, one of the older thrombectomy catheters, uses saline to create this rheolytic mechanism, kind of a Venturi effect. Not so much, it's really certainly black box in the pulmonary circulation, but very important device for these management of these patients with PE, with DVT. Another catheter called the Wolf thrombectomy catheter, kind of scary looking or scary sounding, but it seems to be quite effective. This company was also acquired by Boston Scientific recently. This is kind of, it looks like kind of a conveyor belt where it kind of just conveys out clot from vessels that it's inserted into. The AngioDynamics AngioVac, very mature device. It's basically veno ECMO, basically a large circuit allowing us to suck out lots of clot at maybe a couple liters a minute, and then filters it through a circuit where we can just give back filtered blood. About 22 French system, big catheter, very effective for basically right atrial and maybe IVC clot, not as frequently used for the pulmonary arteries. This company also came out with something called the AlphaVac. This is going to be designed for the pulmonary artery circulation. Again, a relatively large system that has a fancy handle that allows us to suck out clot. And probably the most recent device that I've seen is the Bashir Thrombolex catheter. This is much lower profile, much smaller device, but it allows you, it's got a basket that helps you break up thrombus and then infuse lytic therapy directly into the thrombus. Pretty interesting. I haven't used this yet, but all of these devices are getting approved pretty quickly. There's a lot of interest in this field. In terms of endovascular data, well, there's building evidence. Certainly the ECOS, the ultrasound-assisted lytic infusion. It first started with the Ultima trial, then Seattle 2, and the Optilase PE trials. Basically, the major concern with lytic therapy of any sort is the risk of intracranial hemorrhage. That's the kind of bleeding that worry keeps you up at night. Well, they have almost none. It's less than 1%, or far less than 1% risk of hemorrhage, because you're using much less TPA when you're directly delivering the thrombus, the TPA directly into the clot. The Indigo, the smaller aspiration catheter, that 12 French one by Penumbra, who's really mainstay is stroke therapy. They got approval for PE based on the Extract PE trial, which showed a significant reduction in the RV-LV ratio. Again, we're looking for the recovery of the function of the RV. They noticed a significant improvement at 48 hours. And then the FlowTriever got its 510K approval based on the FLAIR trial, basically touting the fact that you don't need lytics, very few major bleeds, and then significant RV function improvement at 48 hours. They have several ongoing trials, the FLASH, the Peerless, which is a randomized controlled trial, versus catheter-directed lytic therapy for high-risk PE, and the FLAME. I believe their midterm results were just released yesterday, showing that there's been significant on-table improvement of RV function as well as cardiac output on the table after the use of this device. So let's talk about endovascular thrombectomy. That's the whole reason I was probably invited. Let's briefly review the anatomy. So basically, we're coming back up from the IVC. We use a balloon tip catheter to go through the right atrium, the right ventricle, and then into the main pulmonary artery. Now, we take a lot of time to cross the right ventricle because we don't want to go through these guys. These are the chordae. If you pass a 24 French system through these guys, you're going to end up with tricuspid regurgitation. Whether that ends up being clinically significant or not, I don't know, but we certainly don't want to hurt anything. In our experience, we really haven't seen much of that, mostly because we use flow-directed techniques across the RVOT. And this is just a kind of a review of the anatomy. This is the kind of angle we would love to have, though most of the RVs that we see are blown out. So it's kind of more a maze, but we're trying to get through the tricuspid and through the pulmonic and into the main pulmonary artery. We normally measure pressures on the outset. That is a kind of an old school thing where you'd use it to see if a patient could even handle an injection of contrast directly into the pulmonary arteries. Not so much of a deal anymore because contrast is so much less viscous than it was in the past. You certainly want to measure pressures before your intervention to see if you have an on-the-table response. And that seems to be the trend with these patients after an endovascular thrombectomy. I like to get a PAPI score, which is the PA systolic minus PA diastolic over a right atrial mean. I think it's a very interesting way to maybe stratify how the patient may even do. It's possibly a prognostic indicator. So let's talk about our first patient here. It's the 62-year-old male that presented to our service or to our center with sudden onset shortness of breath. They passed out. Syncope seems to be a kind of a concerning symptom. Whenever we hear that, our antennas certainly perk up, and then we kind of really pay attention to those stories a little bit more. Found to have a massive pulmonary embolus, certainly high risk, tachycardic, a little bit hypotensive, hypoxic, requiring a non-rebreather, positive biomarkers, and an elevated PESI score. Now, a PESI score is something we calculate. I really think it's helpful to help objectively stratify these patients. All these criteria are kind of plugged in, and then we kind of calculate a PESI score. Anyone over 100, I get kind of worried about. And certainly someone that has an abnormal lactate, that's somebody that's probably getting sicker. So this is a coronal image of a CT angiogram. This is thrombus nearly occluding the right pulmonary artery, kind of hanging out in the main pulmonary artery. And then you can see some nearly occlusive, not completely occlusive, but some thrombus in the left pulmonary artery. Well, we knew this patient was sick. So as a part of our PERT service, we work very closely with cardiology and cardiac surgery. We plan to do this with cardiac surgery. And our plan was to do it on ECMO. Sometimes we do this completely awake with just a little lidocaine and fentanyl. Sometimes we do this without ECMO support and crash onto ECMO. And sometimes we just know we're going to need the ECMO support. So we just go onto ECMO first and then do our thrombectomy. In this case, we were wise enough to go to ECMO first. In this case, we access the right common femoral vein, get access in the left common femoral vein, and then get left common femoral arterial access. Place our ECMO cannulas. We place a drainage cannula in the intrahepatic IVC for the VA ECMO circuit. Then we go from the right common femoral into the pulmonary artery. You can see these light areas here. That's the filling defects that we saw in CT, large kind of filling defect in the main pulmonary artery, nearly, almost completely occlusive right PA clot, and then certainly a fair amount on the left. Now, I think maybe more important than the volume of clot is how it acts. And if it's acting like it's like completely obstructive, I think that's even more important than how much clot the patient has. As you've probably seen, patients with SAL PEs just sitting there talking to you in room air. Well, that clot's probably not occlusive. It's this clot that really takes the RV down. So from the right groin, we pass this large catheter. This is the Inari thrombectomy aspiration thrombectomy device. We pass it up over through the right ventricle. You can see this bowing of the right ventricle. That's never fun to deal with, particularly after hours. That's because that RV is blown out. And we carefully pass it through the RV into the main pulmonary artery. We treat the right side, and then we go after the left side. And basically, it has a kind of a fancy syringe. And we're simple radiologists. We try to keep these procedures simple. We're just trying to suck out as much clot as possible. And this is what we got. So on the left is the pre, that's what we started with. On the right, significant improvement, particularly in the right. We may have left some thrombus behind in the left, but sometimes I think perfection is the enemy of good in these situations. This patient, we got this kind of clot out. Now, some of this clot may have lysed, but then if you look closely, this fibrinous stuff, you wonder if you lyse this patient, if you give them catheterization therapy, how much would really go away? Would this lead to somebody that gets CTEPH down the road, pulmonary hypertension? We just don't know. That's the problem. There's a dearth of long-term data. So this patient stayed on ECMO for a bit longer. We're actually looking at duration of ECMO in these patients. Hopefully get some information about that soon. And then the RV did recover. Patient decannulated bedside, and then off to rehab. And this patient did pretty well. This is the follow-up CT. We like to get follow-up CTs, and certainly you can see the pulmonary artery is a different story here, kind of wide open. And that's what we started here with on the left. And this is the patient's echo. So this is actually the echo with a kind of akinetic RV, and then a much better squeeze here on the right. Brief talk about ECMO. This is extracorporeal membrane oxygenation. This is where you take in venous flow, and then you pump it into an oxygenator, and you thrust it back into the arterial system. Doesn't make sense. I would have done it the other way if I came up with it, but I'm sure it wouldn't have worked. This works pretty well and certainly supports these patients through a difficult time. This is these large cannulas. They range in size from about 17 French all the way up to 22. Some of them, are even larger. On the arterial side, we frequently put in antegrade SFA access or CFA access to perfuse the limb, because the limbs can get ischemic because these are pretty large access sites. The second case is kind of an interesting case because it makes you think, well, did we really need to do anything? 79-year-old male with shortness of breath, chest pain, presenting. He did have a syncopal episode. That's the story we got. Positive biomarkers, PESI score, depending on when you look in the EMR, range between 129 and 179. Had some left leg swelling. Again, that's our PESI. That's our PESI calculation. And the CT pulmonary angiogram shows nearly occlusive thrombus in the left pulmonary artery. Really, it's amazing that this guy just kind of walked in with a pulmonary artery out like that, and some clot on the right side, but not occlusive. This is a MIP coronal showing the same thing. Very, almost perfectly occluded pulmonary artery, and a little bit of wall adherent stuff in the right. Makes me think that this is a little bit more chronic than we were led to believe. Again, another coronal showing how much thrombus there was. You can see there's significant RV dysfunction. This RV is not supposed to be this big in comparison to the LV. And we ran it through our AI, certainly showing that there's RV dysfunction. We took the patient to intervention. In this case, we did it awake without ECMO support. This is a 26 French sheath that we're advancing up the right common femoral artery, right common femoral vein. You'd be surprised at how well these patients can handle this with just a lot of lidocaine and a little bit of fentanyl. Really need to select the right patients, but it actually works out pretty well. This is the kind of RV you don't want to see in the middle of the night. It's like navigating a maze. This is our aero balloon tipped catheter, trying to get through this big dilated RV with our wire down a left lower lobe branch. And this is what we got here. Completely occluded left PA, as we saw in the CT. We crossed all of that. You can see thrombus kind of going down all the way beyond that large thrombus. Over a stiff wire, we advance our aspiration device, and we do a couple of pulls. Now, we're used to getting a lot of clot out, at least within the first 3 aspiration attempts. You can see we made a little bit of progress, but not enough. We use these nitinol, very soft metal brushes. We tried that several times, really not much improvement. We tried again, some progress, but not enough. I mean, you can see that we have some flow here in the left lower lobe. And then we deployed these, we tried another branch of the pulmonary artery, deploy these discs, these nitinol discs, and that's what it looks like. Again, we're using this to kind of sweep this stuff out of the pulmonary artery. That didn't work so great. Then we used the balloon tip catheter, that Aero 7 French balloon tip catheter, to kind of Fogarty, to kind of pull that clot out. That didn't work. And then we used an aortic balloon that we use for aortic procedures, and it's a 12 French system. We inflated that in the pulmonary artery. Not so much progress there. You can see this balloon going up soon, I hope. Yep, this is what the balloon looks like when we're inflating in the pulmonary artery. Again, we're being pretty aggressive because we need to get this clot out. That didn't work. Then we inflated a non-compliant balloon. And this is what we use in kind of iliac arteries when we really want to crack open a lesion. And then we did a final pull where we're just on aspiration. We pulled this thing out, hoping that we were on some clot. and we pull this thing out of the heart. Now we take our pictures, hoping that we're all done. The left pulmonary artery is wide open, but there is now clot in the right ventricle. The right pulmonary artery. We basically embolized everything from the left side and pulled it over to the right. This new territory embolization phenomenon was first described in stroke cases, but this is the first I saw of it in a pulmonary case. We could not advance a device out to the right pulmonary artery. That RV was so dilated. Patient was stable and actually slightly improving at that point. And we were tired. We didn't want to hurt anything. So we thought, well, let's give him anticoagulation. We came in with a left side of PE, and now he's stable with the right side of PE. We were thinking, well, maybe we shouldn't have. You wonder, should we just anticoagulated him to begin with? And that's exactly how we felt. And 3 days later, we have a CT showing that left pulmonary artery is clean as a whistle, but now you have occlusive thrombus in the right side. A little frustrating, but he's actually doing quite well. Here's an image showing that occlusive right pulmonary artery thrombus. This is the most recent. This is the 3-day follow-up scan, and this is on the right is the scan that he came in with from the ER. Again, still dysfunction of the RV. Still a little concerning, but he's actually hanging in there slightly, gradually improving. Our pulmonologist got a VQ scan. You can see patchy perfusion defects in these images, in these rows here, bilaterally. So it's not like the right lung isn't getting any perfusion, really no abnormality in the ventilation. And then we sent him home on blood thinners. Again, continuous clinical improvement, sent him home on blood thinners. And this is the CT we got at 2 months. RV looks better, and both pulmonary arteries are clean as a whistle. So, we pulled thrombus out of one side, got him out of some trouble, but and embolized it to the other side. He actually improved, but his body was able to do the rest. So sometimes the body knows best, I think. So again, really a clean pulmonary artery there where we had embolized into, and the left pulmonary artery is clean. Another image, another look of this patient's pulmonary circulation. Really not much to speak of there. So 12 months, of course, I'm going to show happy cases here. 12 months follow-up, mild RV dysfunction and echo, but able to carry out his normal daily activities. So he's certainly hanging in there and doing pretty well given what he came in with. So there are lots of controversies in the endovascular care or the PE therapy in general. It does not appear to be like a disease state like stroke or MI, where it's more straightforward and maybe algorithm driven. Endovascular data is not straightforward. Well, that goes back to even the lytic therapy data that we have, going back to the PTO trial, where lytics didn't clearly show a mortality, quality of life, reduction of pulmonary hypertension, RV dysfunction, or CTEPH benefit. So even going back to just lytic therapy, there was kind of questions about that data. And now devices can get approved so quickly and get 510Ks without large randomized controlled trials. And we have this plethora of devices. We have the technology to do these cases. So when it's not always clear, we really need to. So more data is coming, and it's sorely needed. But until then, we definitely need teamwork to load the boat and spread blame on everybody. And actually, I'm kidding, but really that's the importance of working in a multidisciplinary fashion. That and realizing the importance of the right ventricle is the reason to work with team members, particularly in a center that has a PERT team. Thank you.
Thank you very much, Dr. Sarin. Can everybody see my screen?
Yes, it's perfect.
Excellent. I'm Ramesh Mazhari. I'm an interventional cardiologist and the director of the cardiac care unit at the GW. And I'm delighted to be here tonight to talk to you about the management of cardiogenic shock with massive PE. So before we talk about the management of shock, I think it's very important to talk about the distinct anatomic and cardiodynamic features of the right ventricle, because it becomes very important in understanding how the patients with massive PE get into trouble and how we should fix it. So the right ventricle is really a thin-walled and crescent-shaped chamber, and it has three distinct anatomic division. It's the inlet, and then it's the thin and heavily trabeculated free wall and apex, and then a thicker and hypercontractile RVOT. And the arrangement of the myofibrils are also very different between the left and the right ventricle. The right ventricle has a third of the mass and thickness of the left ventricle. It develops much less pressure because it is designed to work in a high volume space without generating much pressure. And it will adjust to the minute-to-minute changes of the venous return. The stroke work index that the RV generates is much less than the left ventricle because it's pumping blood against a vascular bed, a peripheral vascular bed that has 1/10 of the resistance of the systemic circulation. And to complicate things, it's also important to know that both ventricles are actually bond together through myofibrils that will really create a single functional unit. And this becomes very important when we talk about the contractile pattern of the right ventricle. So the right ventricle contractility is also very different from the left ventricle. We're used to talking about the left ventricle as sort of a uniform contractile unit with torsions. That does not happen in the right ventricle. The right ventricle has a sequential and peristaltic form of contractility, and the contractility starts from the inflow, travels down longitudinally in the free wall, and then moves towards the RV outflow with some delay. And 30% of the RV ejection fraction comes from the free wall inward movement, which is really created by the septal contractility. And then the other 70% of the RV ejection fraction is created by the longitudinal contraction of the free wall. And the reason this is important is that it's good to know that 30% of the contractility of the ventricle heavily depends on the left ventricle septal contraction. Because for the rest of the talk, I really want you to pay attention, not just to what the status of the RV is, but also the left ventricle, and the intimate relationship that these two chambers have will actually determine what kind of support devices are appropriate for what phenotype of patient. This is the pressure volume loop. As a cardiologist, I can't give a talk without showing a PV loop, but it basically explains, again, the difference in physiology of the right ventricle compared to left ventricle. This looks very different from the LV PV loop. It's not rectangular. And it basically hints to the fact that this is a low pressure compliant ventricle that can accommodate larger volume without really changing the pressure much. And that is really the key. And my other colleagues alluded to this during their talk, both of them. They said that once you increase the PVR is when the RV fails. The reason is that the way the left ventricle responds to increased afterload is very subtle. The stroke volume and the cardiac output diminishes when the afterload is increased, but not to the extent that the right ventricle fails if the afterload increases. So with a dramatic increase in the afterload to the right ventricle, the stroke volume drops dramatically. So in general, RV failure occurs under two general conditions: excessive RV afterload and LV septal dysfunction. And again, once again, we're talking about the intimate relationship between the LV and RV because it matters. It matters because it actually identifies the phenotype of the RV shock we're dealing with. I have learned that every time I look at a patient in shock, PE and RV shock, I have to really remind myself to think about what the pre-existing myocardial reserve of the left and the right ventricle was before the PE occurred. So the way the right ventricle responds to a massive PE in a healthy 45-year-old with normal LV and RV before the insult is very different than a 75-year-old with pre-existing diastolic dysfunction in the left side who now gets into trouble with the RV. And I'll expand on that a little bit later. So what is the pulmonary embolism death spiral? Well, it starts with a dramatic increase in the PVR by the obstructive clot, which then causes the RV to dilate. When the RV dilates, there is wall stress and ineffective contractility, so the patient becomes hypotensive. In addition, the dilated RV sort of bows into the left ventricle, causes the LV underfilling and hypotension. When the patient's hypotensive, the right ventricle becomes ischemic, which then causes the RV dilatation and the RV dysfunction, and the vicious cycle goes on and on and on. And again, as we heard in the last two talks, the biggest mistake is to give people more volume, because what it does is that it contributes to further RV dilatation and the rest of the story. So obviously, if you want to help the patient, you need to get rid of the initial insult, which is to get rid of the thrombus. And we heard all about that from Dr. Sarin. So when he gets involved and does his elegant procedures, we're working up front on the main issue. But the medical management of the RV shock really heavily depends on assessing the volume, so proper volume management, and also really fixing the RV ischemia. If you cannot fix the RV ischemia, you can't win this battle. So the resuscitation of massive PA and RV shock really depends on whether you understand that the volume resuscitation is a bad idea. So don't give them volume. Do not intubate these patients. The mortality of patients who are intubated is about 77%. So every attempt should be made to delay intubation, because during the induction, the hypotension is worsened and the vicious cycle continues. And of course, pay attention to the RV ischemia and try to fix it. Now, everything between the left and right ventricle has been different, and so is the RV perfusion. With the left ventricle, we know that the perfusion occurs during diastole. With the right ventricle, the perfusion occurs throughout the entire cardiac cycle. And there is less of a pressure flow autoregulation. As a result, if you would like to improve the RV perfusion, just increase the MAP. So the way to fix the RV ischemia is not to start patients on inotropes. That's a really bad idea. You need to start pressors that can increase the SVR and the MAP, and ideally without increasing the PVR as much. And that's a tough choice because most pressors do increase the PVR. But if you look at the literature, norepinephrine seems to be the winner. Vasopressin has been shown to be a very good vasopressor of choice because it actually doesn't affect the PVR as much as the SVR. Phenylephrine is a very effective choice. The problem with phenylephrine is that in order to administer phenylephrine over a long period of time, over hours, you end up giving a lot of volume to the patient. And we have already decided that's a bad idea. Epinephrine is also thought to be a good choice. The problem with epinephrine is that it makes patients even more tachycardic, and more tachycardia with a failing RV reduces the stroke volume. So try to use norepi, vaso, phenylephrine if you can. Once you have accomplished, and I have seen this live, that as the pressure goes up, as you can increase the MAP with the help of the vasopressors, you actually start coming down on the vasopressor requirements because the RV starts waking up. After you have achieved an adequate MAP with vasopressors, then you can adequately introduce inotropic agents, because that can help you with further contractility and reducing the CVP. Now, the AHA definition of massive PE is hypotension with systolic pressure less than 90 or the need for vasopressor support. If you look at the hospitalization sample data, 5% of the hospitalized patients with PE meet this criteria. And we know from older studies that if you give these patients lytic therapy, you can actually reduce the mortality to a great deal. The problem is 30% of patients with massive PE do not qualify for thermolytic therapy. And accordingly, the European guidelines and the AHA scientific statement in 2019 suggests that mechanical circulatory support should be strongly considered in patients with PE and hemodynamic instability, because if the patient has a massive PE, does not qualify for lytics, and you need to give Dr. Sarin and his team a little bit of time to mobilize the team and get their procedures done, the mechanical circulatory support can give you the stability that you need to help these patients actually get through the procedure. How do we do that? Well, there are several options available for RV support. We can look at them and categorize them based on the mechanism of action. The Impella RP, the Tandem RVAD, Protect Duo directly bypass the right ventricle. And the VA ECMO is the only one that indirectly bypasses the right ventricle. We can also categorize them based on the flow. Impeller RP is the only one that provides the microaxial flow through the impeller. The other categories will provide the extracorporeal flow. And of all the modalities that I showed you in the previous slide, VA ECMO is really the one that secures both oxygenation and full circulatory support, and it can be urgently placed without necessarily the need for fluoroscopy guidance like the others do. And it's really the only modality that has been studied, although Dr. Sarin was complaining about the lack of randomized data for different thrombectomy devices. When it comes to mechanical support devices, the data is really muddy. In fact, we don't really have any data, and I can show you some meta-analysis, but no randomized data is available. Now, what does ECMO do? When you put the patients on ECMO, it increases the aortic pressure. It reduces the PA and right atrial pressure, both favorable hemodynamic effects that we want to achieve in patients with RV failure. The problem with VA ECMO is that it actually increases the afterload to the left ventricle. Again, going back to thinking about what kind of left and right ventricle is getting into trouble here. If you have a ventricle that's struggling with pre-existing diastolic dysfunction and you increase the afterload greatly, that patient will have pulmonary congestion and pulmonary edema. And that's when you need to think about bivy support and unloading the left ventricle. So always think about the left ventricle as you're trying to salvage the right ventricle. When it comes to ECMO, all I have to share with you is a collection of small heterogeneous retrospective studies and observations. That's all I have. And when you look at the collective evidence from these studies, it's really hard to really extrapolate any meaningful data. But just like any other meta-analysis, if you try to match the studies and really pick the studies that look the same inclusion criteria for ECMO implantation, we can come up with a few interesting points. One is that the predictors of mortality seem to be consistent across these studies. Again, intubation translates into 80% mortality, CPR, 77% mortality, syncope, 37% mortality. For the lactate, there seems to be a cutoff. If the lactate was more than 6 when you put the patient on ECMO, they still don't do well. ECMO following thrombolytics, very, very bad idea, terrible outcomes due to bleeding complications. So if you look at the meta-analysis, the criteria, the reasonable criteria for VA ECMO cannulation seem to be sustained hypotension despite high-dose pressors, elevated serum lactate, RV dilatation with the RV-LV ratio greater than 1.5, and low cardiac index of 2.1. How about the other support devices? Well, when it comes to Impella, we do have some data, not in the PE population, but Impella has been used in refractory shock in patients after VAD, LVAD implantation, and post-MI shock. What Impella does is very different from ECMO. Impella also improves the aortic pressure, which is favorable, reduces the right atrial pressure, also we like that, but it actually increases the PA pressure. So again, think about it. If you have a ventricle that doesn't, so it increases the preload. So if you have the type of ventricle, struggling ventricle, if there was systolic or diastolic dysfunction before the PA occurred, the left ventricle is not going to accommodate and welcome the unloading of the right ventricle with the Impella. So again, if you do this and the patient remains hypotensive, take a closer look at the left ventricle and plan for bivy support if needed. This is the data, the only data we have for 30 patients on RP Impella, but a different population, as I mentioned, struggling right ventricular refractory shock after LVAD and post-MI shock. And as you can see, the CVP goes down, the cardiac index goes up, so the hemodynamic data is favorable. And in this cohort, which really was not a randomized trial, the 30-day survival was 30%. So my conclusion is the last conclusion slide I use for any shock talk. Early recognition of shock is the key. There's a beautiful paper in January of this year looking at what percent of patients that we call submassive are actually pre-shock? And they started doing SWAN on everybody that they thought were stable. They actually looked at a different scaling called BOVA score. So these are patients that, based on the BOVA score study, this is a European study, they were low risk. And when they did the right heart study, 20% of them were in a pre-shock state. And these are the ones that would collapse and surprise you. So again, just like we did with the post-MI cardiogenic shock, we're learning that we need to phenotype patients in shock. We need to look for earlier stages of shock. And when it comes to the MCS devices, all I can tell you is that they do provide the hemodynamic stability that we need. They are feasible and the hemodynamic benefits are attractive, but we don't have randomized trial. And I can't tell you whether we will, because we've learned from other shock trials that it takes forever to do the trials. And what we are left with is the collaborative efforts across states and different institutions to generate registries that can actually give us the data we need to come up with algorithms and therapies that seem to make sense based on the real world data. And that's all I have.
That's fantastic. Thank you so much. 3 fantastic talks. I really learned a lot, and we really appreciate your thoughts and insights into all of that. We have a little time left for questions and answers, but I would like to turn it over to Dr. Behnam Tehrani to maybe throw out some survey questions to the audience.
Great. Thank you very much, Dr. O'Brien. Thanks to Dr. Druckenbrod, Dr. Sarin, and Dr. Mazhari for some really excellent talks. So, these are really, this is a very interesting topic. It's a segue from cardiogenic shock that we typically think about, because the right side of the heart is one that sometimes is neglected, and in terms of management, it's different, as Dr. Mazhari just discussed with the anatomy and physiology of the right ventricle. So, given the complexity of these patients, that they require upfront stabilization, they require hemodynamic stabilization, whether it's with medical-based therapies or device-based therapies, and then follow-on endovascular therapies plus or minus MCS. A question I want to throw out to the audience is, do your institutions have PE response teams? And if not, do you think you should develop one?
Okay. So
Very
here's
interesting. Does your institution have a PE team? A third said yes, but 4 and 5 people agree that there should be one developed. Very interesting.
Behnam, maybe we should make that another component of the shock initiative.
Yeah.
Kind of kick that around at the leadership level, but this has really opened my eyes to the necessity for the PERT team.
Absolutely. The right side of shock is a very important disease state. Any thoughts from the audience around this?
Oh, hey, it's Mike Contos. Excellent talks. This is an important issue that we deal with fairly frequently. And although there is a fair amount of overlap, a lot of times this is outside the purview of cardiology, and it depends on your individual center. The one thing I was interested in is that as cardiologists, we always like to make things better, and we're always looking at devices to improve things. And although we've tried in a number of different ways, it doesn't always work. For example, the thrombectomy trials in Stemi patients. And it's interesting that with pulmonary embolism, there aren't any great outcomes trials that say that what we do with these interventions makes a difference. So a couple of questions is first, one thought would be, could one better risk do a randomized trial and risk stratify patients a little bit better? using things to identify the intermediate high-risk patients, such as the combination of positive biomarkers with both an elevated troponin and BNP and RV strain to randomize them to intervention or not. And the second would be, what are you all doing as far as risk stratification when you have your PERT teams evaluate these patients? This is something we run into, at least in our situation, all the time. How do we identify the patients that we think are going to progress and do much worse versus those that are going to stay stable? And obviously having that CT with those huge clots kind of drives us to say, well, we need to do something about that, when in fact, if you look at it, the majority of them do quite well. And I think that one case that was presented earlier where it ended up potentially making the patient worse is something that we always do worry about. So how do you all use biomarkers to risk stratify patients and decide, and as far as decide who needs to go into acute intervention, and how do you decide what device to use, either thrombectomy versus 24 or 48 hour directed lytics versus actually surgical thrombectomy?
Yeah, that's a great question. I mean, because, like the case that Dr. Sarin showed with the resistant clot that was noted, sometimes these cases may have to require surgical embolectomy. I'm curious to see what people's thoughts are.
Well, I think about, maybe 3 or 4 years ago, anybody that we thought would need anesthesia for a PE, general anesthesia, those patients, we would always say, go to surgery, get a surgical thromboembolectomy. That has changed with these new devices. I don't think that would be the first line therapy. And going back to some of your other points of that question, it is hard to sort out. As I mentioned, you can get a patient sitting there with a lot of thrombus sitting there in room air. It's very difficult to take a patient who's doing well and then risk a procedure. You have to be judicious. I really do think objective things like the PESI score, biomarkers, I think everyone's going to have some troponin leaks and things like that. But if you have a rising lactate, and again, this history of syncope or something like that, I think I'd be a little bit more concerned about that patient. I'm a big fan of a trial of heparin, 24, 48 hours. I know it sucks to be in the hospital, especially during COVID, but there is a certain number of patients that will slide backwards in the first 24 to 48 hours, and at least you can catch them then. I would probably opt to not intervene in a stable patient, but someone with a lactate and a high PESI score, all of them are going to have abnormal RVs. I don't think that's a way to triage them necessarily. And a good multidisciplinary discussion. The problem is there's so much variability. Even at our center, we have pulmonology, cardiology, cardiac surgery. It really depends on who's on call. You have a very conservative ICU attending on call that night and advocate for medical management. It's a lot of factors, and it's as clear as mud currently. But there are randomized controlled trials going on. Unfortunately, they're all industry sponsored, and it's going to take a while for us to figure out really what to do. There is one trial going on that's NIH funded. It'll take maybe years to fill, but maybe eventually we'll know where to go.
Hey, I'm a pulmonologist at Centra. For patients that have signs of shock or have a high lactate, generally, I think most centers are kind of process is to give TPA over 2 hours first before we consider, thrombectomy type interventions. Or if the patient's not a candidate for TPA because of bleeding risk. I assume that's what most centers are doing. It sounds like there's talk about doing an intervention, endovascular intervention first for these patients. Is the timing and order of these things, am I wrong on that?
I mean, if they're crashing in the ER or ICU and it's going to take an hour for a team to get in, IV TPA is not a contraindication to the endovascular procedure. But what I've seen over at least time at our center, there's going to be people with different risk tolerances to give IV TPA. Though I think it's certainly based on large meta-analysis published in, I think, New England Journal, maybe in 2016, it's really underutilized. IV TPA is definitely underutilized in that scenario.
I mean, I think at our institution, we're pretty aggressive with IVTPA, for patients who, I think we do. I think the comment that was made about under recognition of shock is a real thing. And I've certainly seen patients who get sent for ECOS who are really, truly in shock and should get systemic lytics off the bat. I think we miss that opportunity a lot.
I think one of the thoughts is when you look at some of the trials for lytics, I think it was somewhat biased in that many of those patients were substantially older than what we would see in the acute MI trials and often were post-surgical. So their bleeding risk was substantially biased towards worse outcomes, which I think is different than the patients we often see in the emergency department that are coming in that may be younger that or de novo and don't have that increased bleeding risk. So I think that's something to always take into account, that these trials are not directly comparable to what you see in the ED population.
Yeah, and some of those trials are using different drugs, like the PTO trial, which has the best long-term follow-up. They use TNK. But that being said, I mean, there's clearly, it helped you kind of risk stratify some patients up to the age of 75. The risk of ICH in a healthy 75-year-old is still relatively low.
Is anybody out there using catheter-directed TPA without an ECOS catheter, just a standard catheter?
That's my preferred method of doing catheter-directed leg therapy. I give a lot of credit to ECOS and now Boston Scientific, who owns them now, for getting the first data out. They did the first randomized control trials, but I don't see a clear advantage. And maybe it's lack of experience with it, but it's so much cheaper to use an infusion catheter.
Mm-hmm.
We tend to do that a fair amount too. I think part of it also depends on where your clot burden is. And is it easy to get to? If you can't we're often doing directed lytics, 1 milligram an hour, and then they go back the next day for reassessment. And at times they'll go for another 24 hours after that. And I'm not aware of any great data that shows outcomes, but one would think that the risk of intracranial hemorrhage is substantially less than doing a 2-hour bolus infusion. At least some of the data, at least for catheter, doing a similar type of infusion protocol for valve thrombosis shows a very low intracranial hemorrhage rate. And it would be great to have a randomized trial for that as one of the arms for these intermediate high risk patients using either from mechanical thrombectomy in the IR lab or Cath lab versus directed lytics versus just watching the patient and see how they do over the next 24 to 48 hours. Obviously, I think as we've all recognized that long-term outcomes are really unknown. So I think that's another important endpoint. We can often get them out of the hospital acutely, but what happens 6 months or 1 year down the road to the RV and their exercise tolerance?
The Peerless study is similar to what you're describing, but it's industry funded. And I can't help but see some of the study design obviously is kind of slanted in certain ways, but there's very little NIH funded research.
Very good. We have about 6 minutes left. Did we have, Behnam, did you have another survey? You think we have time for another survey question?
Sure. Do we have the next one up? So what is your approach to massive PE as a first step? This is already discussed. Lytics, catheter-directed lytics, or thrombectomy?
Okay, it's slowing down.
So 60% said systemic lytics. Very interesting. Any thoughts from the audience?
I mean, I think systemic lytics up front for shock are kind of the standard, at least American College of Chest Physicians guidelines.
Yeah,
But, you know, if there's patients at risk for bleeding, then we start talking about thrombectomy.
very interesting.
That's the pulmonary perspective on the
Yeah.
procedures, you know.
Any
I
thoughts
think
from
that's very
others?
reasonable.
I
I will say that I think
comments
industry is
made
trying to
before
get
that
pulmonology
young-
to move forward.
you know, younger patients tend to be at much lower risk of intracranial hemorrhage, I think, particularly if they're not hypertensive patients or have other comorbidities. So, I mean, I think the risk of systemic TPA is so low in those patients.
I totally agree. What I was going to say is that industry is hiring pulmonologists to get a part of their medical director boards and help shape society recommendations towards thrombectomy. So they're being very aggressive, even on the society level, multiple societies to at least advocate for thrombectomy, which is obviously in their interest.
There was an interesting editorial in New England Journal in the last couple of months that talked about this, that the difference between, say, medication trials and device trials are markedly different. For device trials, oftentimes all you need is a 510K. And they specifically addressed pulmonary embolism and the lack of outcomes trials for these particular devices. And it would seem to be a perfect place for CMS to say, look, we'll be glad to pay for your device only if the patient's enrolled in a clinical trial, so we can really determine what the appropriate treatment is for these higher risk patients. Should we be sending them for device therapy, or is it just prone to more complications, and cheaper medical therapy would be advantageous? And I think we missed that chance to do that in numerous different areas, and this would be a perfect opportunity to do so.
I think industry moves so much quicker than we do, but I totally agree with what you're saying.
Great discussions, everyone. Behnam, do you think we have time in the last 2 to 3 minutes? Did you have a third question?
Sure. Do you want to put the third one up?
Yeah, let's do that. And then I promise we'll get you out very shortly.
Does your center perform surgical embolectomy as a bailout strategy or as a primary strategy for these very sick patients?
I wonder if there should be an I don't know answer too.
Exactly. I think
we haven't asked in a long time.
Do it,
but
Pete.
what's that?
I think in a pinch we could probably give it a shot, but it would probably be an uncommon event.
Can you remember, John, in your tenure here, if you've seen that?
I've never seen it here. Yeah.
Very interesting. So 3/4 said yes. Obviously, this is for sites that are have a CT surgery backup and availability. But very interesting. This is a great meeting. A lot of good discussions, a lot of good generated thoughts, and a lot of good materials. Thank you, everybody, for joining us.
Thank you so much to our speakers. Those are tremendous talks. Thank you to VCSQI for all the support and organization. And again, thanks to all our VHAC and shock teammates for the great work you've done. And stay tuned. We will have another one of these meetings in the fall. So we hope to see everybody back. But again, really appreciate everything that's gone into this. And I hope you guys have a great evening.
Thank you.
Thanks a lot.
Thanks, everyone.